5 points of wisdom for sufferers, people with eating disorders. I think number 1 for me was percentages of recovery are increasing, and there are more levels of care. There is greater accessibility to treatment and a wide degree of researched interventions. There is cognitive behavioral therapy, which is probably the most researched, exposure and response prevention that we've talked about, DBT as adjunct skill development and use. CFT is compassion-focused therapy. Founder was Paul Gilbert, and Ken Goss has translated that into eating disorders, and that's more of an evolutionary type approach. And even ACT, acceptance and commitment therapy. So there's a lot of different approaches, and I think as clinicians we have to find the right approach for each person. The next one is social and electronic media play a significant contribution to influencing body image and societal standards of beauty. So pay attention to what you read. Pay attention. Be an advocate. It's insidious. There are also some very positive things out there, so sign up for those. Exploration of how the behaviors function in a person's life is vital. And then appropriate skills are substituted and patience is involved. So the first time somebody uses a skill, I can't tell you how many times somebody's looked at me and said, yeah, Marian, I've tried deep breathing once back in the 60s. It didn't work, so what else do you have for me? The skill didn't work. Bottom line is the skill's not gonna work, you're gonna work the skill. And for skills to work, the best advice I can give is to try it when you're not in crisis. Practice it when you're not in crisis.
That's good advice.
Eating disorders tend to crop up in periods of transition, so be aware of those first thoughts. So grade school to high school, or grade school to middle school to high school to college, getting married, relocating, new job. If you're a military family, relocating there. So pay attention to periods of transition. Rapport within the therapeutic relationship will determine much of the potential efficacy of treatment. So dig deep and use vulnerability and build self-compassion. So here's the don't put your therapist in the position of being Barbara Walters. You know, if you were a tree, what kind of tree would you be? My recommendation is prepare before every therapy session. What does my therapist need to know to best treat me? This is much better done before you walk in the office. So in the treatment program, we would have people do that assignment before they went to their first in-person therapy session. Typically we had a conjoint phone session just so everybody could hear the voice of the therapist and the client. But if you walk in with a sheet of paper that has some stuff on it that you might feel a little ashamed about, at least the clinician's going to get the information, because if I wait until I get there, I might say, they don't really need to know. I tell myself that. So prepare. Don't be in therapy forever. Do what you need to do, move on to the next problem, do what you need to do, and then send us a postcard, right? We're okay with that. Yep. The next things would be what I want clinicians to know, and physicians as well, that you cannot diagnose an eating disorder just by looking at somebody. And yet, there are many screening tools out there. Use them. That's why they're there. All socioeconomic levels, all races, all genders, assess for it. Assessment by a nutritionist is also important. So when you build a team, it needs to be an interdisciplinary team. So typically an inpatient team would include a psychiatrist, an internist, individual therapist, family therapist, and eating disorder nutritionist. Adjunct staff would be nursing and techs and expressive therapies. An outpatient team shouldn't be very different than the inpatient team. You should have a psychiatrist, an internist, an individual therapist, depending on your life situation, a family therapist, and a nutritionist. And that whole team needs to find a way to collaborate. If I know where the patient went with her weight this week, and the nutritionist has seen her earlier in the week, and then she comes to me, then I can talk about what skills did you use? What skills did you not use? How can I help you? Right? So that real-time value is super important. And it's difficult because we're all busy. But if you're going to do eating disorder treatment, it is imperative that you commit to continuity of care and let the team know what's going on in your sessions. If you're not willing to send an email, if you're not willing to make a phone call, then my recommendation is not to be an eating disorder therapist, because it's important to have all the information out there. The other piece was, and I think we've talked about this, it's about survival. It's not about vanity. This is not a lifestyle. It's not a habit. It's not a thing. It's an illness. That's what I've got.